We are so glad you could join us today for the ECG webcast, Physician Compensation Planning for 2021, COVID-19, CMS, and the Economic Realities in Healthcare. I'm Amy Strauss, a Senior Manager at ECG, and I am pleased to be your moderator for today's session. Projecting physician productivity and compensation for your medical group for 2021 looks to be a monumental challenge. COVID-19 has significantly impacted activity patterns, use of virtual visits is evolving, and CMS is adopting a large WRVU adjustment for E&M clinic visits. ECG is poised to help inform your planning effort for next year. Today, we will share practical guidance on preparing for 2021 and how to transition away from your temporary COVID-19 plans. We will also explain how savvy medical groups have built practice economics elements into their compensation plans in ways that buffered them during this pandemic. During today's webinar, ECG's experts will share volume impact insights from our detailed analyses, discuss planning for transitioning away from your COVID-19 stopgaps, and reveal how innovative medical groups are linking practice economics to their compensation plans. Before we introduce today's speakers, let's go over a few details about the webinar. Today's program will be 45 minutes in length. There will be 45 minutes of presentation and 10 minutes for questions and answers. Everyone should have received a copy of the session handouts, but if you are a late registrant, you can download the handout in the handout pane on your screen. Attendees are participating in listen-only mode, but if you have questions, you can type them into the questions pane on your screen at any time, and we will address them at the end of the formal program. If we are unable to answer all the questions today, we will follow up with you after the session. And finally, upon exiting today's program, you will be directed to an electronic survey. Your feedback is important to us, so please take a minute to complete the survey. For each completed survey, ECG will make a $5 donation to Doctors Without Borders. Now let's meet our speakers. Josh Halverson leads ECG's Provider Financial Services practice and is a trusted partner and advisor to the leadership of hospitals, health systems, and academic medical centers and physician groups. With more than 15 years of experience in healthcare strategic and business planning, hospital operations, and physician organization development, Josh understands the challenges that providers face in a volatile and ever-evolving healthcare marketplace. Jason Lee is an associate principal at ECG and has spent more than a decade partnering with healthcare providers to execute strategic planning, hospital physician alignment, and commercial contracting. His current focus is on managed care contract analysis and negotiation, development of hospital-physician financial relationships, and assessment of physician productivity. Maria Hayduke has extensive experience in medical practice development and operations, organizational performance improvement, physician compensation planning, and academic medicine. Maria oversees ECG's provider analytics practice, including the production of our national physician compensation surveys and ECG's medical group and infrastructure survey, cost and infrastructure survey. With these introductions, let's review today's agenda. First, we will review key trends in COVID-19 productivity impact, followed by industry responses to COVID-19, and finally, we'll move towards compensation design economic levers. And with that agenda in mind, I'll turn the program over to Maria.
Thank you, Amy. Let's get right into this section on slide 5. Prior to passing the presentation over to Jason to discuss industry responses to COVID-19 and then to Josh to really get into the meat of compensation planning during these unusual times, I want to spend a few minutes presenting the current landscape that our medical groups are facing and look at some data that gives you a sense of the experiences for medical groups across the country. We all know that the COVID-19 pandemic is negatively impacting healthcare organizations and in turn their financial sustainability. Not only in their inpatient settings, but also in their outpatient activities, as well as their ancillaries. And we'll take a look at how these different arenas are being impacted within medical groups. Back in March, when COVID-19 began, and we began facing the realities of COVID-19, ECG began conducting monthly organization and market WRVU assessments to get a better understanding of the impact of the health emergencies on on providers, on individual specialties, as well as the overall medical group performance. And what we did in this analysis is we began comparing 2020 monthly work RVU production derived from CPT level data to 2019 work RVU production across at the individual provider level, all by specialty, and as well as for overall medical group work RVU production. And we use the 2020 CMS physician fee schedule for this CPT level data to calculate work RVUs. We've unadjusted the data for clinical FTEs. We're looking at actual raw work RVU production from 2019 and compared it to the realities of work RVU production for 2020. On slide 6, so we understand that the data we're presenting today reflects the averages for medical group data that we have, that we've collected for the provider productivity impact study. Everyone's experience across this country is unique right now. We know that individual cities, counties, states are experiencing a different level of impact due to the COVID-19. We have some similarities across the medical groups in April, per se, when stay-at-home orders were pretty consistent across the country. But in March, as the virus began to spread, most notably on the East Coast and in California, the impact was more substantial, whereas in the center of the country, it was more limited. And as I mentioned, in April, a more consistent experience. And then in May, as things begun to change, each organization's experience has been a little bit unique. However, having said that, we have a majority of the organizations included in our study, as well as those who we are doing client work for, we understand that the impact COVID-19 has had on the production has been pretty substantial. What I mean by substantial is more than 30% decrease in work RVU volume, and in many cases, more than 50%. The red dots here indicate a greater than a 50% impact on work RVU volumes within the medical group. So with that in mind, I'd like to get into some of the data that we've collected on slide 7. So this chart presents the change in work RVUs by specialty category year over year for the months of March, April, and May. As you can see here, and we don't have June data ready, it's rolling in right now. We expect to have that within about a week. But as you see here, March, there was an impact to work RVUs. We were down roughly 19% in work RVU production compared to March of 2019. In April, we had a substantial hit to work RVU production of almost 50% down in RVUs. And then we have a slight rebound in May as stay-at-home orders began to lift, as communities began moving from phase 1 to phase 2 to phase 3. And so we're continuing to monitor this and continuing to study the work RVU impact as COVID-19 cases changes across the country. But we do see that, for instance, in primary care for the month of May, we're still down 32%, but it's not quite as dramatic as what we were experiencing in April. Similarly, with medicine and surgical subspecialists have seen a rebound, and hospital-based subspecialists, most notably, have seen a significant rebound. On slide 8, we wanted to better understand how the rebound or how the change in work RVU volume what kinds of procedures and visits are occurring. And so we looked at the CPT data and WRVU data by CPT category. And we are seeing a rebound in evaluation and management activity, in medicine procedures, as well as surgical. The one that's here that is most concerning, I think, for medical groups to understand is in our ancillary activities. As you all know, many of the ancillary procedures that organizations do are in their preventative screenings, in their cancer screenings, for example, or cardiovascular screenings. And the results of those screenings are what really feed the patients into the other subspecialties. And so what we're seeing now in many of our organizations is that the patients were there maybe in March and April and May, but the ones that they would likely see as a result of the screenings, as a mammogram, for instance, they're not seeing because the mammograms aren't happening. So we're going to keep an eye on the ancillary rebound. Once those start up, we expect to have a bit of a recovery across the medicine and the surgical CPT codes as those patients begin to flow again into the other specialties. So I want to take a look at why the evaluation and management codes, why we're seeing a rebound here, and whether it's just the sheer number of patients or is it the type of activity that groups are undertaking to get some of those work RVUs back. And on slide 9, we've taken a look at virtual visits. Some of you participated in a webinar we did at the end of first quarter 2020 where we discussed virtual visits and the adoption of virtual visits as a means to recover some of the production losses that medical groups were experiencing. And we have, in fact, in our data, seen quite a growth in virtual visits across all specialty categories, most notably in primary care. So what the data shows in the table here is that primary care for all evaluation and management visits for the period of March through May of 2019 compared to 2020, that virtual visits make up 19% of all E&M visits for that same period compared to last year, where virtual visits were basically non-existent. Overall, the virtual visits make up about 10% of all E&M visits, the growth from year over year. So we know that there was a hesitancy to adopt virtual visits previously due to lack of understanding of or knowledge of whether commercial payers were going to reimburse for virtual visits, similarly with Medicare. But now that they are reimbursing for the time period, we're going to continue to monitor the adoption of these procedure types and hopefully see that these other medicine and primary care continue to be able to recapture some of the work RVU loss by conducting virtual visits. And I'd just like to point you to the note at the bottom of the page. This activity is the CPT codes 99421 through 99449, as well as all the other E&M procedure codes that were billed with the modifier GT in 95, which Medicare has indicated they would reimburse if conducted via telephone or online. On slide 10, all of this, the work RVU loss has eroded the profitability or and increase likely the net investment required to sustain the medical group. And we wanted to understand, well, what does that look like? We know where we are right now in terms of the impact of COVID-19. We don't really know where we're going to be next month or at the end of the year and into 2021. But just to give you a sense of what that could look like financially, we've taken our 2019 net investment per physician FTE by specialty category that we publish as a result of our medical group cost and infrastructure survey, and overlaid on it what additional net investment would be required across the specialty categories if these loss in revenue continues through the end of the year with only a slight rebound. And as you see here, the impact is quite dramatic. The net investment per physician FTE ranges from $300,000 per physician FTE all the way to more than $500,000 for surgical subspecialists. Josh, did you want to comment?
Yeah, thanks,
on
Maria.
These figures?
Yeah, let me first of all throw out a couple caveats. This is an extraordinarily complex number. We're showing things as averages here, but variables like payer mix, treatment of ancillaries, where they're located in the practice versus in the hospital, have, as well as many other factors, have a pretty significant impact on these investment numbers. And so where we're starting off from differs pretty significantly by hospital system. We're also experiencing, as Maria said before, a wide variety of how volume is changed by specialty and by geography. But I will say across the country, in the conversations we're having as a firm, every single one of our clients have experienced reductions in volume. And there is significant uncertainty of how long it'll take or if even it will bounce back to pre-COVID levels. So while these numbers are may not be exactly the numbers of your organization, we do think that the financial pressure caused by the reduction in volume is directionally very significant and consistent across the industry.
Exactly. Thank you so much, Josh. Finally, I have one more slide, 11. Just wanted to touch upon a couple of additional factors that need to be considered when viewing the landscape and looking forward for the performance of your organization. We know that we expect that COVID-19 will have an impact on production in 2021. We don't know what it will be. So much of it is dependent on treatment options, on vaccine availability, and proliferation across the population. But we expect that it is likely that at least in the first 6 months that we will see an impact to production that's pretty significant and likely will erode work RVU production by as much as 30%. We also know that CMS has proposed making some pretty significant changes to the new and established patient work RVU numbers for 2021 that will have a pretty significant impact on certain specialties. For instance, in primary care, we expect that primary care physicians will be able to generate upwards of 17% more work RVUs in 2021 for the same activity that they did in 2020. What we don't know yet is whether CMS is going to move forward with implementing these changes. There is significant support from physician organizations to do so. We haven't heard from CMS of how they plan to pay for the increases in work RVUs and whether they will implement any sort of budget neutrality factor to balance the increased payout due to the work RVUs. So we don't know a lot, but what we need to keep an eye on is that even if we see significant work RVU erosion due to COVID-19, there's a potential to recover some of that production if CMS moves forward with the planned 2021 RVU changes that have been published thus far. And then lastly, just a couple of things to consider as I pass it on off to Jason. All of the erosion to production is going to impact your many different compensation planning factors, such as setting base compensation, setting production thresholds, economic funding or economic adjustments to compensation pools, establishing market benchmarks. What are you going to do when you get the 2021 benchmarks that were impacted by 2020 COVID reductions? You know, how do you use those benchmarks? And then finally, fair market value implications when compensation levels have stayed the same, but production has fallen by significant levels. So with that, I'm going to pass it off to Jason to get us to present our industry responses to COVID-19.
Thanks so much, Maria. So the question on top of a lot of our clients' minds, and many of you as well, is what should I do with my compensation plan for the rest of this year and likely going into 2021? And we think it's helpful to reflect back on what has transpired so far during the COVID period. Many of you have implemented some type of temporary plan, and we've outlined the three major buckets of the responses that we've seen amongst our clients in talking with them and working with them to develop these different temporary plans. So you can see the three types on slide 13 here. No protection. Some groups just allowed their comp plan to function as it was designed to, and for many physicians that meant some significant reductions in compensation that were commensurate with the changes in productivity. For others, it meant that they had a high base, or that they had other incentives that they were being incentivized on, such as value-based reimbursement or shared savings for lower utilization, and they actually made out better. For a big chunk of the marketplace, a partial protection plan was put in place. Many of you instituted some type of fixed compensation at 80, 85, 75% of your historical, and hope to see what would happen after a 3-month period or 6-month period. And then of course others implemented something much more aggressive or much more protective, where 90, 95, even 100% of historical productivity would be protected, and compensation would be protected. As you can see across each of these three columns, there's different implications that come with those types of protection models and responses from a temporary standpoint. I would suggest that in terms of industry response, if you overlay a normal curve on top of these three columns, that's roughly how it played out and what we saw in the marketplace. And so the bulk of the clients that we work with were in the partial protection category, and a few on either end. So depending on where you're at along this continuum may inform how you decide to transition out of that temporary plan. So as we think about how do I prepare my organization to either continue on or transition out of this plan, there's a couple of key considerations that we outline on the next slide that we think you ought to weigh as you have your discussions and potentially develop your plans. So looking back, or looking at your particular marketplace, how drastic has the drop in volume been? Has COVID impacted me significantly, moderately, lightly? Do we think that the PHE has been contained? If you're perhaps in some states where the threat has been much more contained, or if you're in another state like a Florida or a Southern California where things seem to be less controlled, that's really going to inform part of your discussion here. Of course, how much investment was made in the medical group to date through the temporary plan is going to be a significant question that you need to answer as well, because as Maria noted a few slides ago, the investment in providers and investment in medical groups has been significant over the last few years, and COVID certainly has exacerbated that in many instances. Additionally, strategically, you got to think about, do we have a plan for 2021 to make big changes in our comp plan, or are we just making a few tweaks to our non-productivity incentives for 2021? Do we have an ongoing effort to make those decisions and develop a new plan for 2021 and beyond? Do we have self-system strategies that we're thinking about? Are we shifting into a value-based strategy? Are we shifting into more ambulatory focused strategy? Are we merging with another system, or we're in the middle of merging with another system? And so there's different strategic considerations that need to be weighed as you think about what the transition ought to be. And I'll also add, in our discussions with a lot of systems, the political and cultural implications of how you address physician compensation can be important to weigh as well. If leadership, if frontline staff, if clinical staff are experiencing furloughs and other compensation adjustments, and physicians are experiencing significantly less adjustments, that can certainly damage morale, that can impact the culture of your organization. And so you want to think about that in part as you're weighing how you manage the physician incentive piece going forward. So as you got all of these different market considerations, you put that kind of in a stew, in a mix, and really there are 4 ways that you can transition out of this. And on slide 15, we outline those 4 ways. So you're working on your temporary plans right now. You maybe implemented them in March, April sometime. They've been in place for 3 or 4 months. You may be coming to the end of that time period. And effectively, there are 4 things that you can do coming out of this. You can either return back to your old plan if you think that in your particular area COVID is stabilized. You can stay on your temporary plan right now if you're paralyzed by kind of what's going to happen, if your particular area has a significant rebound of COVID cases, perhaps. You could transition, you could develop an adjusted plan to that temporary plan that might take you a little bit further toward a new plan that you might be thinking about or developing. And finally, of course, you could just switch immediately to that new plan that you either had in ready to implement later this year, or you had to delay that implementation due to COVID. So it may seem relatively simplistic and straightforward, but these are the 4 things that you can do coming out of your current temporary plan. And of course, each of them have some different implications, whether that's greater investment that you need to make in your medical group, whether that's delaying some significant change that you were hoping for, planning for, thinking might be more in line with your strategy, et cetera. So weighing each of those things and thinking about that, how that impacts your medical group, will be important in the decision-making process. So as I mentioned, those market considerations certainly are on a sliding scale for many of you. The tactics that you implement coming out of your temporary plan is going to be unique to your market situation. So as we think about these quadrants on slide 16, the level of what we're saying financial damage, which certainly is the reduction in volume that may have limited your margins or reduced your revenue for your organization, is going to be different depending on where you're at, whether you're a critical access, whether you're an urban facility, whether you were hit heavily by COVID, whether you had rely heavily on elective type procedures, et cetera. And then the other factor that we believe is important is the amount of change in whatever new plan is that you are hoping to switch to. So if you don't have plans to switch into something different or new for 2021, you're going to be farther left on this sliding scale. If you've got a pretty new, pretty significantly different plan for 2021, you're going to be much farther on the right-hand side of this scale. And so you can see how these 2 factors play together to help inform the decision on what we think we ought to do with our transition. Should we return to our old plan? Or if the financial damage is pretty little and our quote unquote new plan for 2021 is not that different, maybe we just switch immediately in August 1st or whenever our temporary plan is over. If the financial damage has been significant to your organization and you're getting nervous about what a second wave of COVID might do in the next several months, maybe you just stay on your temporary plan because that makes the most sense for you. So a lot of different things to consider, and the scale of both the financial implications and the drasticness or the impact of the changes that might come into play for your 2021 plan are what you want to measure. So finally, organizations have been asking us, how do I make this decision? What analyses should I undertake in order to make some of these decisions? And so on slide 17, certainly there's no rocket science to this, but we believe that there's an initial step that you need to take around measuring the net variance that occurred. What has been the impact in both productivity and dollars spent on provider compensation, medical group spend vis-a-vis the historical average, vis-a-vis the first part of 2020, and how quickly has that come back? You know, as you look at the dotted line here, this is just a pure example, but if your dotted line is, to use an economics phrase, more of a V structure or more of a W structure, then you know, that can help inform your decision about where we want to go with the transitional plan. Of course, translating those variances into financial implications is going to be a key next step, right? So once you understand where am I from a productivity standpoint, is it higher or lower in different parts of my service area, or different service lines that are being impacted positively or negatively, translating that into financial implications will allow us to then see what is my overall spend, how does that match up with my budget, match up with my prior historical spend, et cetera, and what do I think we can afford to do going forward for the second half of this year and into 2021. And finally, using that information, weighing the anticipated new case levels, the potential spiking of COVID, and the change in the new plan that I might be implementing in 2021 will allow me to decide whether or not the transition plan looks more like the temporary plan, more like my old plan, or more like my future plan. So a lot of tough questions. It's a little bit more of an art than a science, certainly, than in past years. And we have been working with a lot of organizations to think through this. And so stepping up to the challenge certainly is will be important for the next few months here. So with that, I will go ahead and turn over the next section to Josh.
Thanks, Jason and Maria. So before I get into the case studies, I wanted to do just a quick introduction, or a kind of almost a look backward of how we got to where we're at. And this, you know, this started probably a couple decades ago when I entered or began my career. When hospitals began employing physicians and acquiring physician practices, you often, and I think this playbook still is valid today. For example, physicians who enter into a hospital setting, payer mix often deteriorates because hospitals have mission-based requirements and other kinds of things that require employed physicians to see patients of all payers. Often hospitals put the most profitable services that were previously in the practices into the hospital for a variety of reasons. Practice employees who transition to hospital employment often are more expensive because of benefit rates and other things that just frankly aren't present in practices but are present in to hospital employees. So these and many other issues have, created the need for hospitals to disconnect physician compensation from practice economics. Early, again, in my career, when we were doing acquisition deals, we would try to simulate freestanding practice economics through adjusted revenue, less expense models, or other kinds of things that just became very challenging and problematic to implement and sustain over the years. And so most hospitals went to an RVU-based mechanism that tied compensation to production as measured in work RVUs, multiplied by a conversion rate that would be specialty specific, that was governed mostly off of a variety of surveys. And so what I think is going on here in the industry right now is that COVID has exposed this flaw that has been long present in our economic relationships with physicians and hospitals, that that compensation is not tied at all to practice economics. Now, other reasons why organizations have moved away from direct economics defining physician compensation are things like, what do we think about expense management? Who should be responsible for staffing decisions? What if a physician does not want to move to a different location that perhaps is more expensive, but that's an important strategic imperative dictated by the hospital? So things like expense management and other things get really difficult when perhaps you have conflicting needs and business objectives between hospitals and individual physicians. So again, I don't think there's anything wrong necessarily with the way we've solved these problems through RVU-based plans. It just creates a level of unsustainability. So reintroducing practice economics into compensation is something that we feel pretty strongly about. However, we're not saying that we need to go backward into a revenue less expense model. And so we have three examples that I wanted to go through. The first, and let's go to page 20. The first is a simple, what we call an economic adjustment factor, where you know, an organization is using an RVU-based methodology. Compensation is determined based on the number of RVUs, work RVUs a physician generates multiplied by a conversion factor. This example is from an organization that went through pretty significant financial distress, and historically they had tied themselves to specialty specific conversion rates, and as a result, they frankly couldn't sustain themselves. And this is a pretty extreme example where they went through Chapter 11. And as part of the restructuring process, we needed to redefine how compensation would be determined. Essentially, though, we decided that we wanted to mitigate or minimize any structural changes and preserve the compensation approach using RVUs. However, the key variable we applied was to the conversion rate. So essentially, what we did is utilize an economic adjustment factor that we applied to market level data. So for surgery, if it was $50 per RVU based on a methodology of blending surveys and other kinds of things, starting with the market, we looked at the financial position of the organization and said, okay, our organization, given payer mix, given expense structure, needs to discount the surgical conversion rate by 10%. And so that $50 per RVU became $45 per RVU. And that played out for each of the specialties that we went through. Part of the challenge and part of the conversation philosophically became, what do we think about one specialty having an economic adjustment factor that might be different from another? So surgery, I mentioned the 10%. What if you run through the numbers and look at GI and their adjustment factor was 15%? So we actually went around and around on this topic because part of the question is, do you want to reward practices or geographies that are efficient, that have perhaps different economics, that are advantageous to physicians? And on the other side, do we want to make sure that physician compensation is tied to the true economics of the practice, and if they're inefficiently run or they have other challenges, perhaps their compensation should be less on a per unit basis than other practices? So I don't think there's a right or wrong answer to that question. In this case study, however, we landed that we wanted to have a uniform economic adjustment factor that would apply across the board on a percentage basis, regardless of specialty. And again, that's something that would be revisited, frankly, by the compensation committee every couple of years to decide whether or not we would want to disconnect some of the practices from a common economic adjustment factor. What this allows, obviously, is it creates flexibility for compensation of providers to flex up and down with market shocks. We have an organization that is on a methodology like this that was implemented several years ago, and obviously during the COVID crisis, they're experiencing some challenges. But we would meet them at various opportunities over the years, and they would talk about how their economic adjustment factor would frankly float up when the group was performing well, and everyone benefited from that economic performance. So it actually had a pretty significant impact on bringing the group together and creating a common cause for and motivation for improvements in economics. And that's something that is a feature that we see as actually a very positive outcome out of this. Before I move on to the next one, I did want to mention a couple things. You could imagine that the key variable in this is what is the economic adjustment factor? How do we define it? How is it determined? And we've gone down lots of methodologies with clients around this topic. We've come up with very sophisticated quantitative approaches where we're using objective data. For example, our ECG's medical group cost survey is often utilized at the specialty or service line level to help calibrate this and compare an organization's performance by specialty to an objective standard. That's often useful to calibrate the economic adjustment factor. There are other less sophisticated ways where we look at the financial position of the organization, really compare the averages or to benchmarks in terms of payer mix and other kinds of things, and come up with an adjustment factor that meets the needs of the organization. But that is a key element of this to have some credibility and to be able to implement. I'm going to move to slide 21, which is another organization that essentially went to what I'll call a service line approach, where essentially each service line, each physician was mapped to an individual service line, and those service lines were funded based on a pool of dollars. That pool of dollars was essentially created by tying compensation or tying the compensation funding to the revenues and expenses of that organization. Now, there was a series of commitment dollars that were available to make sure that compensation could be close to or at market, depending on the economics of the service line. But essentially, we went down the process of identifying and designating these service lines into different categories of variable compensation. And what this would mean is that those specialties in this service line would have a lot of influence over their production and value-based reimbursement. Fixed specialties would be those specialties that didn't have a ton of influence over production or value dollars, things like coverage-based specialties. And then we have strategic specialties. So again, what we did is we essentially tied this to a median funding rate at different levels, depending on the ability of physicians to meet these criteria. Essentially, what happened, though, the distribution within the funding pool is very service line specific. And this could be applied to at a practice level even, where the distribution took those dollars that were funded and then had a mechanism that was established to meet the business objectives and the cultural identities of each of those service areas. So the point of this is that disconnecting funding from distribution is something that can be very helpful to allow physicians' compensation to align with the organizational priorities and the priorities of a specific economic unit, but also making sure that we have funding levels that are tied to the economics of the organization. I'll go quickly through the last example on page 22, which is an organization in California where the medical group was connected to a hospital through a single professional services agreement. The funding model was based on productivity as measured in RVUs and other administrative requirements that were essentially added on to a pool of dollars. One of the problems, however, that was present when we got there was there were physicians who were pretty significantly productive, and if you ran the distributions based on the current state, what would happen would that their compensation would surpass what was available in the funding amount. So in order to mitigate some of those issues, we established for distribution purposes what we designated a payout ratio that essentially guaranteed that the funding amount would not be exceeded by individuals who are high producers. And what that allowed is that everyone essentially had an opportunity to proportionally participate in that funding based on their performance. The ratio constrained the amount that was paid out to make sure that we didn't pay more than we had available. It also enabled the organization to react positively when more production happened, as well as negatively when collections were lower than expected, because that ratio is tied to both production and collections. The last thing I wanted to say, and I'm close to being out of time, is many of our organizations are facing unprecedented financial distress. When we look at productivity patterns and other kinds of things, there are organizations that had excess capacity even before COVID. That excess capacity is being exacerbated by the COVID situation, and many of these organizations are faced with the question of, do we have too many physicians chasing too few patients, and are we able to sustain the most expensive resource in the organization in terms of provider compensation? So I would also put on the table that many organizations are being forced, frankly, to look at their provider footprint and right size that footprint to match the new patterns in patient demand. And so the luxury of carrying excess capacity in physician or APP providers is frankly not available for many of our organizations. And so when we think about compensation and tying compensation to things around production or throughput or other types of things, making sure that we have the right number of providers is really a critical exercise that many organizations are going through right now. So I'm going to pause there and maybe hand it over back to Amy to open it up for questions.
Thank you, Josh. Before we move on to our questions, a reminder to our audience to please continue to enter any questions into the questions pane, and I will ask as many questions as time permits. With that in mind, our first question is geared towards Josh. What type of group is best suited for a practice economics lever? Can I do this if I've got a small group?
Yeah, we've actually implemented it in both large and small groups, employed and independent groups. So I think that this is often a very easy way to ensure the connection of compensation to the economics of the organization. As I mentioned earlier, some of the challenges is how do you think about, is that economic adjustment factor varied by specialty or by location? And having the ground rules set for that decision, as well as how to set the economic adjustment factor, every year, every couple of years is critical. But usually this works, really well in multi and even single specialty situations. So I would say that this is, if you are on a productivity-based plan that uses RVUs, this is an easy way to keep most of the structure in place and preserve kind of the elements that you already have.
Perfect, thanks, Josh. Our next question is, do you suggest adding some bonuses or other incentives to ease adoption and acceptance of the practice economics adjustment factor?
I'll jump in, and then Maria and Jason might have some thoughts on this. So this is a challenge as you think about this, and if the organization has, and maybe we have I have a skewed sample. Sometimes we go into organizations that are financially distressed and frankly don't have that luxury of providing some sort of cushion. It's obviously easier to have some cushion. We often recommend implementing, what we call bands or buffers of anything plus or minus 3 or 5%. There's some sort of protection around that. So if that luxury is available, we often recommend doing that. Sometimes, and especially right now, that is not an option. So yes, and I think it's on a case-by-case basis. Jason, any other comments on that?
I would agree with that sentiment, and I would also say that another way obviously to implement this is incrementally over a period of time and transition into something that's a bit more aggressive. So some of your classic guardrails would apply in any of those types of models.
Another thing, just really quickly to jump in, Amy, before you move on. As I mentioned earlier, it really depends on what we're sensitizing compensation to and what that economic adjustment factor includes. And so when I think about, staffing decisions, lots of organizations have spent years, frankly, wresting the decisions around staff away from physicians and turning it into a group or administrative decision around, using benchmarks and other kinds of things. If we're now reintroducing staff expense or space expense into that EAF, that often goes against what has been going on over the past year. So care in philosophically thinking about that is something that really helps the adoption of things. Frankly, lots of organizations are perhaps looking to turn back on some of the entrepreneurial spirit of the physicians, and so there are places right now who are saying we want our physicians to be involved in making decisions around staffing or other kinds of things on the expense side of the equation.
Great. Our next question is, which type of metrics or levers do you recommend we use for the economic adjustment factor?
Yeah, the classic ones that we've used are things like payer mix. Again, the RVU-based models are based on assumptions that, the market norms in the industry, as measured in those surveys and other kinds of things, represent kind of a typical physician practice and the resulting economics from that practice. If your organization, for example, has a superior or inferior payer mix on a monetary scale than the averages, that's an easy thing, very easy to understand, to make an adjustment to, and recognize that our mix of patients isn't like the median or like the averages. So therefore, that's easy. As I indicated earlier, on the expense side, we often look at things that physicians have control over or at least have some influence on. Staffing are very easy elements to look at, making sure that if you're staffed higher than on average, for example, things that can make an adjustment. Again, space is a really tricky one, but is often necessary in some of the elements of discussion. So those are the variables I would say we look at. The last thing I would say is when we think about managed care contracts and the proportion of revenue that's tied to managed care or value or other kinds of things, using that to calibrate the economic adjustment factor is often really important as well.
Thank you. Our next question is, what insights do you have on how the national commercial health plans will compensate for virtual care post-COVID? What about considerations for Medicare?
Jason, do you want to take a crack at that?
Yeah, I was just going to say, having spoken to a couple of colleagues at health plans, it seems like there's more acceptance of having parity around reimbursement for those services and having more liberal rules around how those can be deployed. Because as everybody knows right now, prior to COVID, they were pretty strict. You basically had to be in an urban market and serving somebody that was, 150 miles away, if you will. But I think that organizations, both CMS as well as commercial payers, due to largely a lot of state laws that are coming into place around reimbursement parity, are going to be changing that. And so, I think that the virtual visit bump that we illustrated earlier in the deck is probably going to hold to a large extent. It's not going to float all the way back down to virtually 1 to 0%. And so due to that, I think folks are finding a lot of efficiency and value of televisits. And I think that the reimbursement is going to be much more allowable for those types of situations.
let me tag on one comment to that, Jason and Amy. As we all know, virtual services is actually a suite of services, and there's a true virtual visits where it's very much like an E&M. It's just not face to face or in person. It's just over the internet. But when you have asynchronistic visits through emails and other kinds of things, I literally was on a call earlier this morning where physicians were concerned or didn't understand that those types of visits, those asynchronous visits, were not reimbursed or did not have the same work RVU value as E&M visits. And so understanding, and I think it's really important to educate physicians and providers as to what the differences are and how that impacts productivity is really important to manage expectations, because a lot of the information that they're receiving is incomplete and usually stops when the sentence is said, we're going to pay parity for virtual visits without consideration of the different types of services that are being provided. So that's one thing I would just suggest, that's something we can all do as providers to manage expectations.
Perfect. Thank you both. It looks like we have time for one or two more questions. Our next question is, will ECG be continuing its month-to-month trending study for the rest of the year? And if so, how can I participate?
I'll take that. Absolutely. We plan to continue our monthly COVID production study through 2020 and into 2021 as necessary. We're actively collecting data right now and are adding organizations as they request to be part of the study. And when we do that, we also go back to March and collect data so that we can analyze your performance from the beginning of the emergency. I think there's a question in the post-session survey, and so if you're interested, please reach out. Also, my contact information is on one of the early slides in the presentation, and please feel free to email me and I'll send you the materials to begin participation. The study is free to participate. There is no fee, and so we would encourage all of you who are interested in tracking your provider's performance through COVID-19 to reach out to us for participation.
Thank you, Maria. And with that final question, that concludes our formal program. Please note that if you asked a question that we were unable to get to, we will follow up with you after the session. We would like to also make you aware of ECG's extensive library of thought leadership on COVID-19. Visit our website at www.ecgmc.com to learn more about these and other relevant topics. I would like to again thank all of you for attending today's presentation. If you have any additional questions or comments, please don't hesitate to contact one of us via the email information provided in the handouts. One final reminder, we would greatly appreciate if you could take a moment to complete the electronic survey upon exiting today's program. As stated earlier, ECG will make a $5 donation to Doctors Without Borders for each survey submitted. Thank you, everyone, and have a good day.